The rectum is the lower part of the large intestine which connects the sigmoid colon to the anal canal. This 10 to 15 centimeter stretch of the large intestine is particularly notorious to develop cancer. Cancer in the rectum starts in the form of a polyp. Now this polyp is usually a benign polyp which can be diagnosed on a routine endoscopy, but sometimes these polyps turn malignant and then the cancer cells invade into the rectum lining and then into the surrounding tissues. Well, the exact reason is not known, but the risk factors for developing rectal cancer are cigarette smoking, frequent alcohol intake, being overweight or obese, low intake of fresh fruits and vegetables in diet. Well, in our country, most patients, they come with the history of having frequent passage of fresh bright red blood into the stools during defecation, and these symptoms are often attributed to piles or hemorrhoids, and this goes on for quite some time, and it is only after they are evaluated by a specialist that rectal cancer is confirmed on endoscopy and biopsy. Other symptoms apart from rectal bleeding include either constipation or rectal pain while passing stools. Once rectal cancer is diagnosed, then it has to be staged. And to stage rectal cancer, the most important test is a pelvic contrast enhanced MRI scan. This MRI scan tells us the depth of penetration of the rectal cancer into the surrounding tissues and whether there are any enlarged lymph nodes in and around the rectum. Apart from this, a contrast CT scan is also recommended of the chest and the abdomen to rule out if the cancer has spread to the distant organs like the liver or the lungs. Once the CT and MRI scan is done, the stage is confirmed and then the treatment is decided as per the stage. So there are 4 stages of rectal cancer: stage 1, 2, 3 and 4. Stage 1 is when the cancer is in the very early stage and it has only penetrated a small part of the wall of the rectum. Second stage is when the cancer has penetrated a little bit deeper into the rectal wall. And the third stage is when the penetration is even deeper and there are also enlarged lymph nodes around the rectum. And stage 4 is when the cancer has spread to the distant organs like the peritoneum or the liver or the lungs. The treatment also depends on the stage. Now for the first stage of rectal cancer, usually only surgery alone is appropriate. That is, if it's a malignant or a cancerous polyp, a simple polyp removal suffices. For little bit more advanced stages, that is stage 2 and stage 3, the treatment includes not only surgery but also chemotherapy and radiation therapy. Now, several trials have been done to study the best combination of these 3 treatment modalities, and world over the current accepted paradigm is what is called as total neoadjuvant therapy or TNT. Now TNT entails that the patient complete all the treatment of radiation and chemotherapy prior to surgery. The radiation therapy can be either a short course radiation consisting of only 5 sittings, or it can be a long course radiation which goes on for 5 weeks. Which radiation to give is depends on some other factors which are discussed with the patient in detail after reviewing their MRI reports and other reports like the endoscopy findings. The chemotherapy again can either be a little less intensive chemotherapy consisting of 2 chemotherapy drugs, or it can be a little bit more intensive chemotherapy with 3 chemotherapy drugs, and these are given for usually a period of 4 to 6 months. After chemotherapy and radiation is completed, after giving a break of around 6 to 8 weeks, the MRI scan is repeated and then the next plan is decided. Now the standard treatment is surgery, in which the affected part of the rectum is removed. And here the surgeon has to decide whether or not to do a low anterior resection or a abdominoperineal resection. What is a low anterior resection? This is basically when the rectum is removed and the remaining part of the intestine is joined back to the anal canal so that the patients can pass the stools through the normal way. But if the cancer has spread very deep down into the anal canal and it has involved the anal sphincter which maintains the continence, then it is usually not possible to do a low anterior resection, and then the surgeon has to do what is known as an abdominoperineal resection or APR, in which the entire rectum and the anal canal is removed. But the problem with this surgery is that the patient has a permanent colostomy, that is, the intestine is joined to the abdomen and the stools come out in a bag, and that bag has to be changed frequently. This causes a lot of quality of life issues because no one wants to have a permanent colostomy, and it is always the attempt of the treating team to avoid an abdominoperineal resection as far as possible, but in some cases it is necessary for attempting a cure of the tumor. Unfortunately, despite all this treatment of chemotherapy, radiation and surgery, still a few patients they relapse. Out of 10 patients who are treated with curative intent, at the end of 3 years, around 3 to 4 patients would have a relapse. And this relapse can either be in the local site, that is in the rectum, in the operated region or around the operated region, or they can have a distant relapse which is a little less common, either in the liver or in the lungs. The treatment then depends on the type of relapse and the duration of the interval for which the patient has been free of their disease. Now there are a very small minority of rectal cancer patients, around 1 to 2%, who are deficient for mismatch repair. This is a particular type of uncommon mutation which happens in the cancer cells, but those patients who have this deficient mismatch repair, they respond exceptionally well to immunotherapy. And you might have seen this 100% response rate news a few months ago in the media, when around 12 patients who received this immunotherapy drug, all 12 patients had a complete disappearance of their tumor. But this is a very uncommon mutation and the majority of rectal cancer patients do not have this mutation. The other more exciting new development for rectal cancer is that it is now possible to offer non-operative treatment for some patients. Now out of 10 patients, around 4 to 5 patients might be eligible for non-operative treatment, in which we give them TNT therapy, that is chemotherapy and radiation, and then put them on a very intensive watch and wait surveillance strategy, in which they have to undergo frequent endoscopies and rectal MRI scans, etc. And at any future risk of recurrence, when we suspect a relapse, at that time they can undergo surgery. So with this strategy, quite a few patients can safely avoid immediate rectal surgery and thus have a better quality of life.